So now I've great pleasure in inviting Professor Albert Ong to speak to us.
Well, thank you very much for the invitation to come and speak to you today. Yes, I think particularly enjoy the warmer weather. When I left England, it was still below 10, so I thought, great. Anyway, I was asked to kind of give you an overview about PKD, and I'm glad to see that there's a healthy, thriving patient association starting in Australia. We've got one in the UK called the PKD Charity, which I've been kind of involved with over many years, and I think it's a really important step in trying to get more informed about what your condition, what you can do as a community, and engage with your physicians more, because sometimes patients know more about their disease than the physicians, unfortunately, but you can be kind of the people who change things for the next generation. So today I want to kind of focus about, I was given a very broad remit, so I hope it's not too boring. But Charmaine said, "Oh, could you say this? Could you say this? Could you say this?" Because I said, "Well, how much time have you got?" I mean, so I'll try to kind of give you a broad overview, and hopefully, there's something you can take away. Everyone can take away something from this meeting. I've kind of titled my talk "The Changing Face of Clinical Management" because I think we're really in an exciting time. When I was a medical student, we didn't know the genes that cause ADPKD, but now we know the genes. We can screen for the disease, and we have the first treatment. So I think there's a lot of reason for hope for the future. And I think one thing I hope that you leave this meeting is feeling more positive about the future for yourself and for your children and the rest of your family. Okay, right, so going back in time, so this is going back 150 years. So this is a picture of a polycystic kidney that was hand-drawn by this French doctor, Pierre Raillet, who was one of the first people to recognize it. Now, he actually recognized it, unfortunately, after death. So he was doing post-mortems and actually found that some people unexpectedly had these huge kidneys. And you can see why it's called polycystic kidney. I'm not sure I've got a pointer. Do I have a pointer? No. It's okay. Yeah. But you can see why it's called polycystic kidneys. The kidneys are full of these little blisters. He called it cystic degeneration. And basically, but it's essentially a polycystic kidney. And he said, this looks like an illness without cure. And of course, he was seeing people after death, and clearly they had died, but maybe from something else. But actually, until recently, you could say that actually that was true, because there's nothing we could have done about it. And and unfortunately, that has been the case for 150 years. So in terms of how common it is, I mean, you have some information on these posters, but this is data taken from England and Wales, and shows that basically patients who develop renal failure because of PKD are the fourth most common cause of renal failure in the UK. And in our population is 1 in 10. So 1 in 10 patients who start dialysis to have a transplant, that's due to ADPKD. It's not the most common, but it's pretty common. So in terms of prevalence, so prevalence is where we say, if we look at the population as a whole, how many people have PKD from studying the whole population. So figures vary, but we probably have agreed to a figure of about 1 in 2,500 people in the population. So when you wander around the streets of Melbourne or Sydney, wherever you live, you probably count the number, and every 2,500 people, one person with ADPKD. So it's not very, very common, but it's certainly not rare. You can calculate from the population of Melbourne how many people are affected with ADPKD. Now, this figure may be an underestimate because many people have PKD and don't know about it. So I'm sure some of you will be, recognize this yourself, and until you had a symptom or you had a scan for some other reason, you didn't know you had it. So you kind of happily going upon your way. And more recent studies suggest that actually maybe the frequency or the prevalence could be as common as 1 in 1,000. So a lot more people walking around Melbourne and Sydney with PKD, but don't know about it. Okay, we think it affects all ethnic groups, so all races all around the world. It's been found in perhaps 10 million people worldwide. although the global population is increasing. Okay, so it's not just a kidney disease. So this is a slide just to say that actually, we focus on the kidney, but actually there are other organs affected, and Stuart actually gave a very clear account of that within his family, that actually for example, 20% of patients have what we call polycystic liver disease. 80% of people will have liver cysts, but polycystic liver disease is where the liver gets really enlarged and actually can be more of a problem than the kidney. And it's more common in females, but although I have male patients who've got very bad livers, but 2 in 10 have got big livers. 6 out of 10 have a lot of pain from their polycystic kidneys. Most of the time it's because the kidneys are big. 8 out of 10 have high blood pressure, so even if your kidneys are working fine, make sure you get your blood pressure checked and treated, because that's important. 3%, 3 out of 100, have a risk of developing aneurysms. So aneurysms are, if you like, weaknesses of the blood vessels in the blood. Particularly here, we're worried about the brain. And sometimes in some families, the first presentation is of a sudden stroke, often in a young person. So at my age, everyone who's young is less than 40. But, it can happen at any age. But sometimes, out of the blue, someone has a stroke. Very young, no problems. And then they find, actually, that's because they've got polycystic kidneys. So probably on average, 1 in 10 people have aneurysms, but we don't know who they are. That's another story for another day. Doesn't mean they need treating, but actually the best thing you can do, whether you know you have an aneurysm or not, make sure your blood pressure is well controlled and don't smoke. Okay, so those 2 things, take-home messages. Now, if we look at how common is this, so if you're thinking to yourself, gosh, I'm the only one, and this is rare, how many people have it around the world? So I've given you a kind of upper figure. This is data from the European Union. So this is actually from the EU 27 countries, soon to be 26, unfortunately. But we look at this is data from the European Union, and if we look at all patients who need dialysis or a transplant across the European Union, you can see that the figures here show that from 1993, over a 10-year period, the number of people having ADPKD and leading to renal failure has gone up to about 50,000. So clearly we're now 6 years down the line, so it's probably going to be more like 70,000 to 80,000. So a lot of people, and these are just people who needing dialysis treatment or transplant. And this actually comes at a huge cost. So this is the cost economically to the European Union, 1.6 billion euros per year for dialysis or transplant treatment. And until recently, I would say that this is probably what we do for patients. So here we have the best evidence practices for treatment is that we try to detect blood pressure early and treat that. We treat any other factors that may predispose you to developing heart attacks or strokes, such as cholesterol, diabetes, etc. We treat any infections or pain. We manage any other complications, such as the liver problems or aneurysms. And then we basically say, we can offer you dialysis or a transplant when needed. And so I would sort of summarize that this is, in a nutshell, this is what most nephrologists do, that basically we make the diagnosis by ultrasound. Prognosis just means outcome. So what is your long-term outcome? You ask your nephrologist, they say, well, actually, don't know. Go away, make sure you come back when your kidney function is less than 20%. And then until recently, nothing to offer, but tolvaptan, certainly within the UK, has been used for the last two years. In Australia, I believe it's just been approved, so that's something to look forward to. Now, if we look forward maybe another 5-6 years, I think this is kind of what we're looking at. So we're looking at ultrasound, but also genetic testing is going to become more common because genetic testing can pick up cysts even before the ultrasound can. In terms of outcome, we can use different techniques. So genetic testing, depending on the type of mutation you carry, that is more or less severe. I'll give you some information about that. And then MRI. So MRI is where we take a picture of the kidney to look at the size of the kidneys using magnetic resonance scans. And that can give us an idea of whether you're likely to fall into a good prognostic group, a bad prognostic group, or something in between. All right, gives you an idea of how long your kidneys are going to go on for. So I think this is going to become standard care. And then finally, I think we're looking at tolvaptan, but it's going to be tolvaptan plus something else, or something else. So it's kind of a phase of change. So tolvaptan is the first, it's not the last. I think we're going to be seeing a huge number of drugs coming on stream. Okay, so let me talk a little bit about diagnosis. So how do we make the diagnosis, and particularly about genetics? So you can make the diagnosis by looking at the gene that you carry, or the one that's in your family. Now, there are two genes that cause the bulk of all what we call dominant polycystic kidney disease in 90% of cases or more. And these genes are called PKD1 and PKD2. So when the genes were identified, we didn't have a good idea of what to name them, so they're just called polycystic kidney disease 1, polycystic kidney disease 2. The doctors are not very imaginative. I'm sure you could have come up with better names. But PKD1 accounts for about 8 out of 10 patients. So if you were a betting person, you would say, well, my chances of having a PKD1 mutation are 8 out of 10. 2 out of 10 have got PKD2, all right? So, and different types of mutations. So mutations are like spelling mistakes within the gene. And the spelling mistakes can fall in different places and cause different problems with reading the message of the gene. And essentially all types of spelling mistakes have been found in the gene. And almost each family carries what we call a private mutation. That's your family's mutation. Not shared with many, many people. Every family has its own. Very rarely we find that certain families share mutations. They're not related, but they just happen to be in the same place. But unlike some other diseases, where 70% of cases are due to one mutation, in this case, every family has its own. So in terms of screening, we can actually look at individual families and find out the mutation. So if you know the mutation in your family, for practical purposes, you can go to your nephrologist and say, this is the family mutation. Can I check that I carry the same mutation? And that could be important for certain reasons. For example, if you want to be a kidney donor, you're not sure whether you're affected or not. That's a clear-cut reason for doing that, and so on. So in terms of actually other genes, I've told you that PKD1 and 2 account for 9 out of 10 patients with ADPKD. It turns out that there are a lot more genes that can account for a few families. So we now have 4 more genes that we think can cause a similar disease. And if you like, they're going to be called PKD 3, 4, 5, and 6. All right? So if you really want to impress your doctors, you say, do I carry PKD 1 or PKD 6? And you'll say, what? All right. So they've not been called PKD 3, 4, 5, and 6. They've been called even more complicated names, which are the ones in yellow. So I'm not expecting you to remember this. There will be no test at the end. So, but basically, they can be rare. And if you check for PKD 1 and 2, and the doctor says we've not found a mutation, it could be one of these rarer genes. So we're now starting to test for them as well, right? So that's basically something about genetics and something about the new genes that we've identified. So secondly, I want to talk about prognosis. So prognosis is basically where you want to know, okay, I carry this gene, I have ADPKD, what's going to happen to me? I want to know, looking into my crystal ball, what's going to happen to me 30 years down the line? What should I be prepared for? Do I need to do something now? So prognosis actually turns out to be highly related to the mutation you carry within your family. So not much you can do about that, because you've got the gene from your mum or dad or whatever. And it turns out that essentially, which gene mutation you carry, that does determine your outcome on average. I emphasize the word average because even within the same family, we see big differences. But let's say, so if you carry a PKD2 mutation, that's the line in red, the average age at which your kidneys will survive for is 80. Right? So now I know we're all living longer, but 80 is not bad. So you could argue that actually that's good. So I can kind of relax a bit and perhaps do take my tablets, but I may not need tolvaptan. All right. But however, if you carry a PKD1 mutation, which is the common one, remember, which accounts for 80% of all cases, 80% probably of people in this room, then it depends on the question next is what type of mutation, which type of spelling mistake I have in my gene. Is it what we call a stop mutation, so that mutation actually stops the function of the gene message completely, or in this case it's called T or truncating, or is it a spelling mistake that kind of like it's not as severe? Because if you carry the severe one, the average age for your kidneys will last till it's 56. If you carry the less severe one, it's 68. So if you like, we can think about, you can ask yourself, which group do I fall in? Do I fall in, the best group, the worst group, or something in between? All right. So it has some information, some power to tell you that. But I emphasize the fact that each individual is different. But you start with you either carry a bad gene or a not so bad gene, and then everything else is kind of due to other factors. Now, based on this genetic information, but also adding clinical information, this group based in France have actually calculated a score. So this is what's called a pro-PKD score. So pro stands for prognosis, which is this funny word we use for saying how outcome. Prognostic PKD score. And it gives you a score of 1 to 9. All right? So the 1 to 9 is based on the fact of what gene mutation you carry, okay, and whether you're male or female, whether you develop blood pressure before or after the age of 35, whether you have any symptoms before or after the age of 35. So just to give you an example, if you were a female, if you're a woman, you carried a PKD2 mutation, you had no symptoms, or you had symptoms after the age of 35 and your blood pressure is normal, you have 0 points. Okay, so that's very good. However, on the opposite scale, if you were male, sorry guys, PKD1 truncating mutation, bad mutation if you like, symptoms at the age of 20, and blood pressure at the age of 30. That's full house, that's 9 points. Okay, so you can work out probably for yourself where you're going to fall if you know your history. But you need to know your mutation, all right? So you don't know your mutation, you can't really calculate the score. So one of the problems using this is, of course, we don't do genetics as standard care in the UK. Most countries don't do this. But I think it will become standard care because the cost is falling and it has useful information. So you may hear this pro-PKD score, and this is what it refers to. Now, in terms of the other scoring system is using MRI. So this is a picture of one of my patients with polycystic kidneys, and the red areas are the cystic areas, and the blue areas are non-cystic areas. You can see that how big the kidneys are at his age. Now, essentially, we can use the size of the kidneys at the age at which you do the scan, corrected for height, and that gives you an ability. It gives us an ability to put you into different classes. All right. So this is what doctors are kind of thinking about now. And essentially, if you look at, I'm sorry, I don't have a pointer, but basically, I have to go to this side. So basically, this is a patient who's got 1A, and if you go up there, that's the worst, which is a 1E. And basically, you could see that those patients here are at the same age. So at the age of 40, the kidneys are very, very different. Yeah? Based on that, so the simple idea that this was derived from was that basically, if you have bigger kidneys at a younger age, you probably got worse disease. Very simply, because by nature, it's one of those diseases that cause your kidneys to get big. So if you have big kidneys at a young age, you're going to do worse than someone who has smaller kidneys at a young age, in a nutshell. And you can kind of do some calculations and put it into a formula. And basically, by having a scan at a fixed age, say at the age of 25, you have a scan. We calculate how big the kidneys are, both kidneys. We enter into a formula. We divide it by your height because that corrects for between men and women. And that enables us to put you into 5 different categories. And basically, they correlate to how quickly the kidneys are going to decline 30 years down the line. Okay, so this was done with a group at the Mayo Clinic where they had information going back 30 years. So they asked the question, if we had knowledge 30 years on the scan, now we're 30 years later, can we go backwards and have said, well, actually, could we have this predicted that? Does that make sense? Okay. So, so based on a single scan, we can then starting to make some projections. So, for for the sake of simplicity, 1A and 1B put you into a good category. So 1A and 1B we would say low risk, okay, or slow progression. C, D, and E put you into high risk or fast progression. All right. So the importance of this is actually the fact that not everyone progresses at the same rate, and secondly, not everyone needs treatment. Because actually, if you're progressing slowly anyway, you're not going to benefit from treatment. All right. And some of this is clearly influenced by the genetic mutation you carry. Some of this is influenced by whether you're male or female, and other factors will also come into play, which we cannot define. But the earlier you have symptoms, probably the more severe disease you have. Okay. Fine. So in terms of treatment, what can we offer now? So you all probably want to hear about tolvaptan since that's a new treatment that's come up. So just to give you some background as to how tolvaptan was developed. So this was the kind of what we call the most important study based in a mouse model of polycystic kidney disease that really gave researchers the reason to go into human studies. So tolvaptan actually is a molecule that blocks your ability of the kidney to retain urine, to retain water. So basically, if you take tolvaptan, you pee. Because the natural hormone, which stops you from going to the toilet, retains water, is blocked. So it cannot work. So tolvaptan blocks that ability of that receptor to act on the kidney. So you just pass a lot of urine, and you have to drink water. Otherwise, you just become a crisp. Okay. I know Australia is short of water, but make sure you have plenty of water to drink. So if we look at the pictures, you could see that basically a mouse that was treated with the drug, this time it's got the magic number called OPC, did really well. Yes? So that's the kidney cut in a section. And then on the right side, the kidney's not cut. So you can see that the kidney is actually much smaller when they've been treated. Now you could say, well, actually, that's one mouse. What does it matter? We're not mice, are we? And then they tried it in several mice and found that actually different types of mice and found that they actually behaved the same. Mice that developed polycystic kidneys. So this was the reason for going into the human trial. So the human trial was called Tempo 34. It was what we call a randomized controlled trial. So here where we say have a group of patients and they don't know what they're going to get. They're going to get either the active drug or dummy, sugar, and neither does their doctor know. So the doctor doesn't know, the patient doesn't know, they're just randomized, okay? And the reason for that is, of course, if I was up to me, I would give it to my favorite patients, of course. The ones who, nice to me and so on. The ones I don't like, I would give them, So we all have biases, right? Conscious or unconscious. So we need to do these studies so that we're not biased and we get the facts and the truth. So in this study, they recruited 1,500 patients from around the world. They randomized them 2 to 1. So your chances of getting active drug were 2 out of 3. So it wasn't 50-50. So your chances of getting drug were more higher than not getting drug. They looked at patients with early disease and big kidneys because those were the ones they predicted would have more severe disease, would progress faster. So more chances to see an effect. And the primary endpoint, by which I mean what they were measuring before and after, was the size, the rate of growth of the kidneys. Because as you can imagine, I've told you that this is a disease where the kidneys get bigger and at a predictable rate. So if we could slow the rate of growth of the kidneys, then that's a sign that the drug is working. But also they measured kidney function. So those of you who might have heard of EGFR, that's a kind of often what nephrologists use as a measure of kidney function. And they looked at other measures like pain and complications and so on. So, and in a nutshell, the trial was positive. So basically, if we look at this, the left graph, for example, the patients who were on tolvaptan, their kidneys grew 50% slower than those who were on placebo or dummy, if you like. So that's a quite a clear effect. So the blue line are those on tolvaptan, the red line are those not on tolvaptan. If we look at kidney function, the slowing of kidney function, again there was an effect. So here again the blue line goes, if you kind of declines slower than the red line by about 25 to 30%. Okay, so less remarkable than the rate of growth of the kidneys, but still a clear effect. So this is the first drug that actually has been shown to slow kidney function decline and the rate of growth of the kidneys. And so based on that data, this data, the European Medicine Agency and the UK body called NICE decided to approve the drug. So we've been using it. So within Europe, the last 3 years, UK was a bit slower, so 2 years. We've been using the drug based on that. Okay. Now, the Americans, the Federal Drug Administration, decided that data was not good enough. We want a second trial. So the company, thankfully, did a second trial because for a number of reasons. And essentially, the second trial reported at the end of 2017 and fortunately was also positive. So in this case, they decided just to measure the rate of decline of kidney function rather than measuring the rate of growth of the kidneys, because that was an issue, because people said, well, if you can store your kidneys getting bigger, who cares, as long as the kidney function, that's the main thing. You can still start analysis with smaller kidneys, but, it doesn't matter. So what they found was actually that if you looked at the reading of your kidney function before you went on treatment, and 1 month after coming off treatment, this is a very short study over a 12-month period, they found that actually patients who are on treatment, which is in the blue, patients who are not on treatment in the red, the rate of decline was, again, 30% less if you are on treatment than you are on treatment after 1 year. And these are patients who are more severely affected. So we're looking at patients whose kidney functions were down to 25%, whereas in the original study, it was more like 60%. So clearly, it has an effect not just in the early stages, but also in the late stages. All right. Sometimes patients find it difficult to understand, what this benefit is taking tolvaptan to me. And one way to understand this, which I sometimes use as a simplified explanation, is that if you want to get the benefit of tolvaptan, you need to take 3 years of tolvaptan to buy 1 year. Okay? So 3 years on treatment to buy an extra year of kidney life. Yeah. Okay, so who needs treatment? So I've already told you that not everyone is the same. And one of the problems also is that kidney function declines late. So often the kidneys grow to a very big size. If we just measure blood tests, we can't tell because the kidney is remarkably able to compensate. It overworks, if you like. The kidneys, the bits of the kidney that are not full of cysts, do extra work to compensate for the ones that are cystic. And all that time, the kidney is growing. And then finally, the kidney sort of can't compensate anymore. The normal bits can't compensate, and then it starts to go. So when you start to see a drop in your kidney function, shown as the graph on the right, it's probably too late in the sense that, it's already at a stage where it's going to go down. And basically, that's why, patients and physicians can be fooled because they think everything is going fine. Why worry? And then it starts to drop. And when it drops, it starts to go down. It doesn't stop. All right? But so we had the approval of tolvaptan, and basically, that there's a difference between does a drug work, okay, and should it be used, and who should get it. So I think that's a different question. So then we know the drug works. And when should we use it? So when do we start? What sort of group of people? And who should get it? So basically the European Medicine Agency basically said, okay, you can prescribe tolvaptan in different European countries. You have to obviously have the condition. Secondly, we're only going to allow you to prescribe it for patients whose kidney function is at least 30%. So 30% and higher, because that was what was seen in the trial. And thirdly, we're only allowing you to give it to patients who have rapid disease progression, so kidneys who are deteriorating at a rapid rate. So what is a rapid rate? So a rapid rate we defined as 2.5 mils per minute per year. Now 2.5 mils per minute per year, 2.5% per year if you like. And that is equivalent to what is on the Mayo class a 1C. So does that make sense? If you go back to that kidney, I told you there are 5 classes. So 1C, D, and E would be a rate of decline predicted of greater than 2.5% per year or more. Okay, but actually, when we looked at the different countries have done their own thing. So some countries have been much more open and permissive in terms of, we don't care, as long as your kidney function is greater than 15, you can have it. Some countries are saying, well, your kidney, we only allow you to prescribe between 30 and 90. I think Australia has gone for the 30 and 90, which is identical to the UK guidance. All right, but so if you have, unfortunately, if your kidney function is greater than 90, if it's 91, then you have to go to Scotland to get it. So all my English patients go to Edinburgh or something because they, no, not really, but we sometimes just measure it till it drops below 90. So, but anyway, so that's the situation. So not everyone is needs to have it, but you have to have evidence that your kidney function is declining at a particular rate. Now the situation has changed slightly because of the second trial. I told you that the second trial looked at patients who had more severe disease. So patients who had GFRs less than 30, so 25. So actually the European Medicines Agency has now allowed patients in Europe to take it whose kidney function is less than 30, but 25. So 25 and above. But I'm not sure that Australia has allowed that. So Australia has followed the UK, about England and Wales rather, very strictly. But I think at the moment it's still, 30 to 90. So, but in Europe you can get it sort of below 30, 25 to 30. Okay, so now this is kind of more or less how summarizing some of the things I've told you already. So in terms of who is eligible, I think based on the trial kind of evidence, we would say patients with ADPKD from 18 to 55. I don't think Australia has imposed an upper age limit, neither has the UK. So I don't think you need to worry about that. So this is kind of just more like what, the evidence, but what actually you're allowed to do in practice is different. You have to have a kidney function of greater than 25, but in Australia it's 30. Okay, so not all of this applies to Australia. Evidence of rapid disease progression, by which I mean greater than 2.5% per year, is that's the evidence we're applying, or 5% per year over 1 year, which in my practice never happens, or you fall into the Mayo class 1C to E, or your kidney volume is greater than 750 mils, right? So those are the kind of what we based on the trials and so on. So you don't need to know all that, but basically I think the main thing you need to remember is that do I fall into a rapid disease category, if you like, yeah? Then in terms of dosing, what we do is that we start with 45 milligrams in the morning and 15 milligrams in the evening, and we titrate the dose up over in our case it's every month. And then over 3 months, we reach a maximum of 120 milligrams, or the highest tolerated dose. So in our practice, we would only keep someone on a minimum of 60 milligrams a day as the kind of minimum dose of effectiveness. And basically, as in Australia, I suspect, as in the UK and other countries, you have to have your liver function checked every month. And at the same time, your specialist may check your kidney function because it's just another blood test. But liver function, because in the original studies and in the second trial, 5% of people had their liver's tests became abnormal. 2 cases in the first trial and the 3rd case in the second trial developed much more severe inflammation of their liver. So this is a safety issue. You will not be allowed to take tolvaptan without having that done. Now, in my practice, probably we've had 2 patients out of about 30 who've had to stop it because of their livers. But I could not have predicted which 2. So you just got to accept that that's part of the monitoring schedule. We're required by law to do that. I think the same in Australia. Okay, so coming to an end. So I've told you about what's going to happen, what used to be, what is happening now. It's almost going to, what about the future? Just projecting forward, imagining the future. So I think we could think about combinations. So I want you just to kind of like dream a bit and imagine a bit. we could think about combination. So tolvaptan, as I told you, is not the end, it's just the beginning. And what's the evidence for that? So this is again an animal study where they've combined two drugs. So T is tolvaptan, I think, and P is another drug, all right? You don't need to know about that one, but basically, if you look at B is both, and WT is wild type, so that's the normal mice. So on the left side, you've got the polycystic mice, C, control, T treated with tolvaptan, P with drug number 2, B is both tolvaptan and drug B, P, and that's your normal. So you can see that actually adding another drug to tolvaptan in mice actually does help. So we could think about 2 drugs, not 3. At the moment, we only got 1, but you know, it could be 2, it could be 3, right? Next, oh gosh. Okay. What about other options? So what could be drug number 2 and number 3? Well, this is a summary of, say, 14 possible drugs, all right? So 14 possible drugs that we kind of looked at in terms of science, so people who are doing research and so on, using animal models and cell models. So 14 different possible new drugs that could be developed. Now, there's no way that 14 new drugs are going to be developed into trial. To develop one single drug will cost $2 billion to take that from the beginning right till the end. So there's no way a company's going to spend that much money, or the government could afford that money. But some of these drugs will be developed, and there will be new trials starting. So I would encourage you that if you are either not wanting to take tolvaptan, or you cannot tolerate tolvaptan, or you think, well, I want to do something for the next phase, there will be trials, and they will be asking for volunteers to take part in these trials. We need to do the trials, because without the trials, we cannot get information. Without information, we cannot get a drug approved. So, we're not mice. So we need your participation. So I think if you're asked to take part in studies, do give it some consideration, because without those 3,000 patients who took part in those studies, we wouldn't have tolvaptan. All right, so put it that way. So I'd give you that opportunity, that challenge, if you like, to take part in the next studies. Okay, what else? I think we kind of in a phase where we're beginning to realize that actually what we should be also looking at is not just the kidney function, but also about other things that matter to patients. So this is a study that we did in Sheffield a couple of years ago, and just asking people, how do you think ADPKD affects you psychologically, emotionally? And to my surprise, actually, in my population, so I run a polycystic clinic, probably have about 500 patients with polycystic kidney disease in our center. We just did a questionnaire and just said, okay, how is it affecting you? We really want to know. And some things came up that perhaps are not surprising to people here, but was a surprise to me. So, for example, we found that actually many people felt guilty about passing on the disease to their children. And for some people, it was causing significant depression. So I think it's something that we hadn't kind of realized, and we started to offer sort of psychological support and availability to counseling and so on. But if you feel like that, you're not the only one. I think it's something that you should try to deal with, or try to kind of get help with if that's an issue. Obviously, concerned about progressing your kidneys failing and when that's going to happen, that's obviously a big concern to many people. And finally, people felt that actually, obviously, it was causing more problems in their life. And I hope that through the care pathway for patients is going to become more patient focused rather than medical focused. So I think hopefully, as we become more aware of what we can do, we're also aware of the support that patients need in coping and living with their condition. Okay. Oh, it's not going. Right, okay. And I think if I was given a lot of money or put in charge of developing services, this is what I would do. I think basically often, patients get very frustrated because often you know more about the disease than your physician. Many people say they go to the doctors and I know more than the doctor. And you go away feeling very frustrated, not being heard, and you think, gosh, what was that? It was a waste of time. So I think we should sort of start to think about a more holistic pathway for care. So in terms of thinking about information about your condition, thinking about possibilities of screening for the kidney, but also for non-kidney complications, and also thinking about treatments and how that's going to impact you, and how that's going to what sort of care you should have. And clearly, not every centre or every physician can be an expert in PKD. We wouldn't expect that, but perhaps we need to think about sort of perhaps some centres which have more expertise that could provide more support for those. So I think perhaps in Australia, as in the UK, that would be something worth developing and supporting. We need to think about the disease, how the disease affects patients, not just for the kidney, but also talked about the liver. I talked about aneurysms. I talked about pain. I talked about the challenges of having children. How can we prevent in the next generation, etc. Fine. And just finally, I think this is something we've developed as a kind of tool for patients. So this is developed with PKD International, so with a group of European experts. And it's a very interactive sort of web-based thing that you can download. And actually, it's basically the lifetime care pathway for patients. And you can click on each one, and actually it comes up with a list. So it's very, very useful, or rather we would like you to use it and actually maybe give feedback if you think it's useful or not useful, how it can be improved. So it's been out for about a year or so. You can download it for free from the PKD International website. That's the web link. And you can click on each one, and it comes up with different things you can find out. And you can actually then go to your physician and say, actually, this is what it says I need to have, or whatever. Then say, oh, they could look at it too. And so I think that really want that to be a well-used tool for patients. Okay, so I started off with this slide. I'll just end with this slide. We don't have a cure, but we have the first treatment. I think there's a lot of reason for hope. I hope we can find a cure, but we have the first treatment, and the first of many. Thank you for your attention.